everyone. It's great to see so many of you joining us. I invite you to say hi in the chat and let us know that you're here and where you're from. We welcome you all and thank you so much for joining us tonight. My name is Stephanie Paul and I am the Executive Director of MyFace, and I am pleased to welcome you to our program. This web education program is designed for families of children with craniofacial differences, caregivers, and healthcare providers. I would like to thank the Milbank Foundation for funding this important program and acknowledge their appreciation for the critical need to provide educational programs like this one for families of children impacted by craniofacial differences. MyFace has a long history of providing access to comprehensive medical and dental care, along with education and direct patient services, paving the way for better patient outcomes. At the heart of our approach are three pillars of support. First, through our grant funding to top-level organizations across the nation, we deliver quality, comprehensive craniofacial care to ensure that patients receive surgical, dental, psychosocial, speech, nutritional, and other aspects of care in a coordinated fashion. Second, through a range of direct services, MyFace aims to meet the day-to-day needs of the craniofacial community by offering support groups for affected children and adults and parents, distribution of newborn care kits specially designed for babies born with a craniofacial difference, and housing families traveling to New York City for treatment. Finally, we strive to educate patients, families, and healthcare providers through programs like this Transforming Lives webinar series, and to raise public awareness about craniofacial differences through our Wonder Project school assemblies and our monthly podcast, My Face, My Story, Voices from the Craniofacial Community, where individuals can share their stories, be seen, and be heard. MyFace is here to bring together the craniofacial community and help transform the lives of children and adults living with facial differences. We believe everyone deserves the chance to thrive and live the best life possible. Now on to our program. Our presenters today are Dr. Eustachian Sanders, pediatric audiologist of Seattle Children's Hospital located in Seattle, Washington, and Dr. Randall A. Bly, associate professor of pediatric otolaryngology, head and neck surgery at Seattle Children's Hospital and the University of Washington School of Medicine located in Seattle, Washington. We will also hear from our family speakers, Austin and Courtney Cole. After the presentation, we will open the program for questions from participants. As you think of questions for our speakers, please enter those questions into the chat on your screen during the program. It is now my pleasure to turn the presentation over to Dr. Sanders.
Okay, hi everyone. So the first thing that you can see on your screen is just a brief summary and outline of the things that I'm going to cover for my portion of today's presentation. So we're just going to jump right in. So we'll go first to our ear anatomy slide. So our ear is made up of three major parts. So we have our outer ear, we also have our middle ear space, and our inner ear. Your outer ear is a part of the ear that you can essentially see. So this part is your pinna, and you also have your ear canal, which leads to your middle ear space. That's where we have our eardrum or tympanic membrane, as well as the three smallest bones in your body. We also have our Eustachian tube that leads to the middle ear space, and that equalizes pressure in your middle ear space to match outside in the air. So like, your Eustachian tubes are working when your ears pop on an airplane. Beyond your middle ear space, we have our inner ear, and that's where we have our cochlea, and that's our hearing organ. We also have our balance organs in your inner ear as well. And then beyond there, we have our hearing nerve. Okay. So now we're just going to talk a little bit about the different ways that we can transmit sound. One being air conduction and one's bone conduction. So air conduction is when sound travels through all three parts of the hearing system. So your outer ear, through your middle ear, all the way to your inner ear. So how we hear on a daily basis is ear conduction. But we can also look at hearing through bone conduction testing, and that skips past your outer and your middle ear space, and it tests just the inner ear directly. And it's really helpful for us because it kind of helps us to determine type of hearing loss. And I'm going to discuss different types of hearing loss on the next slide. Okay, so we have three major types of hearing loss. The first being conductive hearing loss. So conductive hearing loss, and there's a little diagram on the right side of your screen there, is a problem with your outer and or middle ear space. But your inner ear, where your cochlea is, works just fine. So some examples of conductive hearing loss are if you have like occluding or impacted wax, or if you have fluid or an ear infection, those types of things. If you have microtia atresia or a stenotic ear canal, those things can cause conductive hearing loss. Sensory neural hearing loss is a different type of hearing loss, and that's the picture on the bottom right-hand corner of your screen. And that is an inner ear problem. So a problem with your hearing organ. Those are more permanent hearing losses, but for sensory neural hearing loss, your outer and your middle ear space work just fine. And then mixed hearing loss is kind of a mixture of the two. So you can have like a permanent hearing loss, and you can also have like an ear infection at the same time. So now we're going to get into a little bit about different ways to test hearing. So from an audiology standpoint, we have multiple different tricks and tests in our bag of tools. We do multiple tests to put things together to tell us about hearing and how healthy your ear is on a given day. So based off of the age that your child is, the testing may look different. So when babies are young, so under the age of 6 months old, we don't even require their participation for the testing. We put a series of different stickers or electrodes on their head, and we kind of look at how their brain is responding to sounds, and we can measure the responses from their hearing nerve. All they have to do is sleep for the test, and it's really non-invasive. It's a great way to do testing. You may hear it called like an ABR or a BEAR test. It's also the same way that we do newborn hearing screenings as well. And then as kids get older, once they're able to kind of sit and have some head and trunk control, we can teach them to test behaviorally. So the bottom right-hand corner of your screen, you can see that the little boy is looking when he hears the sounds, or we can teach the kiddos to play when they hear the sound. So we can make it really fun for the kids, really engaging, and we can get really good, accurate tests once they're able to participate behaviorally. And then we can also do standard hearing tests where the kids raise their hand when they hear the beeps, or they clap their hands, or they tell us when they hear it. And there's a variety of other things that we can also do as well, but those are kind of just some of the big major ways that we can test hearing. So now we're going to get into a little bit more about potential devices after I briefly explain this audiogram to you. So this is how we plot hearing results. So whether we do it from a sleep test, whether we do it from a behavioral hearing test, we put the scores onto this graph. So on the top of the graph, we're looking at low pitch sounds all the way to high pitch sounds, very similar to a piano. And then on the left-hand side of your screen, we're looking at volume. So really quiet sounds are at the top, really loud sounds are at the bottom. And essentially you're looking for the normal range is closer to the top of the graph. So you have to be touching 20 or above. And then depending on how we send and transmit sounds to your child, so whether we're playing it from a speaker or if we're putting headphones on, the scores and how we mark those scores on the graph may look different. You may see like X's or O's or S's, just depending on how that test was completed. But the goal for normal is to be closer to the top. Okay. All right, so now we're going to talk about some different hearing devices. First, we're just going to briefly discuss traditional hearing aids. So you may or may not have ever seen a traditional hearing aid, but for pediatrics, they can be a little bit more fun. So that's why I put so many fun colors on here. We can make it really fun for kids. So for traditional hearing devices, the computer portion of the hearing aid sits behind the ear, and then it's coupled with either an ear mold or some type of a dome just to kind of keep it on the ear. And essentially it sends sound through and into the ear, and we have different ways that we can program and adjust it and make it so that it's specific for your child's hearing loss and for your child's ear canal and acoustics. We also have on the bottom left-hand side of your screen different types of hearing aids that we can prescribe for kids that are a little bit older, that are a little bit more discreet. I mean, they could be fun colors as well, but we can make it a little bit more discreet as our kiddos get a little bit older. They may not want everyone to see their hearing aid, so we have a variety of different options. The biggest caveat for a traditional hearing device is you have to have an ear, you have to have a pinna for the hearing aid to sit on, and we also have to have an ear canal in order for this device to work. So now we're going to talk a bit more about bone conduction sound processors, but I wanted to briefly mention that a surgical bone conduction sound processor, or otherwise known as an Osseo integrated bone conduction sound processor, is different than a cochlear implant. So if you see it, they look really similar because it's a hearing device that's kind of connected to the head, but they're completely different. Cochlear implants are for patients with severe to profound sensory neural hearing loss, meaning their hearing organ doesn't work or function the way that it should. And it's FDA approved for much younger kids. Whereas what we're going to focus on today with bone conduction sound processors, that's for like conductive hearing loss or even a little bit of a mixed hearing loss. But your inner ear has to work just fine. And then it's not FDA approved until kids are a little bit older. Okay, so I just wanted to briefly mention that before I talk about the surgical options here. So I know this is a bit of a busy screen, but I kind of wanted to show the different options that we have available. So on the far left-hand side of your screen, the Osseo is one of the newer devices, and it is an Osseo integrated bone conduction hearing device. And for that device in particular, it's only FDA approved for children that are 12 and older. It's really sleek, really thin, and it just connects to the head via a magnet. All three of the devices all have an internal implant that essentially looks like a screw, and it becomes one. It also integrates, meaning become one with bone, and then all of them have some sort of external piece where you put the external hearing device with it. So for the abutment, there is an abutment that kind of protrudes ever so slightly from the head, and you kind of snap the external hearing device or processor to it. And then as well for like the attract, it has a magnet that you snap the external device to and then put that onto the head. The abutment and the attract are FDA approved for kids that are a little bit younger, as young as 5. So kids can be candidates for that a little bit sooner than they can for the Osseo. And then for our little babies that are younger and that can't get surgical devices, we have different devices available for them that we're going to show you here on this next slide. And those can be worn on either this soft band, and then we also have this sound arc that I wanted to mention. So the soft band is used most often for bone conduction sound processors when it's not a surgical device. It has really great retention, meaning once we put it on, it stays in place really well. We're not concerned that it's going to fall off or that it will be uncomfortable or anything like that. We also get really good programming when we use the soft band, meaning I can make sure and ensure that I'm sending good and consistent sound to your child, and we can fit it on infants and babies. The only thing is we do have to make sure that the baby's head is a little bit bigger. So not on infants, but at least big enough for the headband to fit. We can only make it so small. But we can fit it on really young children. We can also use that device for kiddos that aren't interested in surgery or that aren't the best surgical candidates. And then I also wanted to briefly mention this sound arc as an option. It kind of looks like if you have sunglasses, wearing them like backwards on your head, and essentially it does the same thing. It sends sound via bone conduction and stimulates your inner ear. But I really only recommend that device for like kids that are a little bit older because they have to be able to adjust it and make sure that it's set well, and I wouldn't recommend that for like a 2-year-old. So yeah, that's all I'm going to say about the devices for today. And then I wanted to mention some recommendations for kids with hearing loss. So whether your child has a permanent hearing loss or if they have a hearing loss that we think may go away in the future, these are all really good recommendations. So the first being, if your child is diagnosed with a hearing loss and is recommended to use a hearing device, no matter what device it is, if it's a traditional hearing aid or if it's a bone conduction sound processor, we recommend full-time hearing device use. So as soon as you wake up in the morning, eyes open, put your ears on, put your hearing device on. And full-time use, other than when you're sleeping or showering or going swimming, we really want to have your hearing devices on at all times. The next one that is a really big point is establishing care with early intervention. So early intervention is special programs that are designed to support learning and development and to try to really help get the best outcomes for your child and for your family. So there is ample research to show that the earlier that we start intervention, the better. So especially for hearing, we like to follow a 1-3-6 model. So having screenings for hearing done by 1 month of age, diagnostic testing where we diagnose and find if there's a hearing problem by 3 months of age, and then intervention by 6 months of age. There's a lot of research that we have to show that kids' linguistic outcomes are much better the earlier that we are starting the intervention process. And that's for like learning and hearing language, for speaking, talking, all of the above. So really kind of getting started with early intervention as soon as you can. Also monitoring hearing regularly and keeping up with monitoring and following up with your audiologist as consistently as they recommend, and following up with your otolaryngologist or your ear, nose, and throat physician as consistently and as much as they recommend that you come in. And then this last slide has a few more recommendations. And the biggest one is just using good communication strategies. And this is actually good for not even just kids with hearing loss, actually just for all people. It's really good to optimize your listening environment. So gaining your child's attention before you start speaking to them, and decreasing background noise. So like not talking over the dishwasher running, not talking from a far distance. So not trying to give instructions across the house, really kind of getting close and impersonal with your kid. And that way they have the best outcomes of hearing you optimally. Also speaking at a reasonable volume, and enunciating, pronouncing your words clearly. Don't hesitate to repeat and offer repetition, and even check in to make sure that your kiddo heard really well what you said. And then ensuring that they also have like facial cues that they can read from as well. I think my biggest thing and biggest takeaway that I really want you to all have is, no matter what is recommended for your child, if we're recommending watching, making sure that you're using these good communication strategies, getting set up with early intervention, and if a device is recommended for your child, establishing use immediately and full-time use is really, really highly recommended. Right. And I think Dr. Floyd's going to go next.
Thank you, Adriana. Hi, everybody. Randy Bly, I'm very excited to be here. And so this is what I'm going to talk about, is the common hearing loss presentations in craniofacial conditions. We're going to talk a little bit about the cause of hearing loss to add to what Adriana has done. In this portion, where time is a little bit limited, we're going to focus on conductive hearing loss. And again, that's the problem with sound getting in. Of course, sensorineural hearing loss can also be present, sometimes even both, and we have different ways to manage that. And then we're going to spend a good amount of time talking about what we actually do and offer, whether that's observation or using some of the devices that Adriana discussed, and some surgical options. So mild conductive hearing loss. Again, this is a problem with the sound getting in, whether it's the ear canal, the eardrum, or the ear bones. And let's think about first just common things with mild conductive hearing loss, as we often see with fluid behind the eardrum. In almost any condition that impacts the Eustachian tube will, and there's a little purple line showing where the eardrum is there that I've just added. And then this is where the space that fluid fills. So whether this is a common ear infection, this is where the problem occurs, is behind the eardrum, the same space as where the ear bones are. And then this causes the ear bones to move a little bit sluggish. The Eustachian tube, I've just highlighted the arrow that points to that. When that Eustachian tube is an interesting tube, this one is a normally closed tube, and then it intermittently opens to equalize the pressure. So if this tube does not open, fluid will accumulate behind the eardrum. That can sometimes cause an infection, but will mostly cause, if it's there for a long time, will cause that mild hearing loss. And I've listed just a large range of conditions that can have Eustachian tube dysfunction. And here we are going to the next slide. I wanted to walk you through a scenario you commonly see. So this is an example, just as it can be, like, again, fluid can occur behind the eardrum for a variety of reasons. One of the most common we see is a patient with a cleft palate. And typically around 8 months of age is when Asiana is able to do some of this behavioral hearing testing. And we have an audiogram. This is the graph that we've shown on the right here. And you see that dark line at 20. And this patient has a hearing result just below the normal. So has mild hearing loss. We look down at the red and blue tracings down at the bottom, and that's the result of tympanometry. Tympanometry is a way to do like a pressure test to see how well the eardrum moves. When fluid is behind the eardrum, it doesn't move as well. And so this hearing test can tell us that there's mild hearing loss likely due to some fluid. When we look in the ears, the image on the right is an eardrum with fluid behind it. We would probably see that in this instance. Just for reference, a normal otoscopy or normal picture of an eardrum is on the left. And so when we see this, and many times the patients will not have significant symptoms. Many times an 8-month-old will be responding pretty well. Often will not necessarily have infections, but will have this mild hearing loss. And so as we move close to the time of palate repair, typically around 12 months, which can vary, we would talk about placing ear tube as an option to remove the fluid, and with the main goal of improving the hearing. This is what an ear tube looks like in the ear canal. So this is a really zoomed in picture, and the eardrum is in the distance there, and you see a very tiny ear tube. These are soft, they're silicone, just over 1 millimeter in diameter. Ear tubes, again, are typically done in patients with cleft palate at the time of the palate repair, but can be done outside of that as well. Again, for any time that there's fluid behind the eardrum for more than 3 months, or we anticipate it being there for a long time that's causing a conductive hearing loss, this is an option. This is a very quick procedure. There's a small incision away from the ear bones. We remove the fluid, we put the ear tube in there. It typically comes out on its own in 1 to 2 years. The benefits, like I mentioned, are the improved hearing by keeping the space behind the eardrum dry. And it possibly might help with ear infections. Again, if ear infections weren't the main reason leading into it, it may not be there. But if an ear infection does occur, it can be treated with ear drops instead of antibiotics. The risks are overall low. There's a small risk that there could be a hole left behind in the eardrum after the life cycle of the ear tube. The risk of that is 1 to 3%. And that's a fixable problem if that occurs. Sometimes we need to repeat the procedure. So if we do the ear tube and then after the cycle of fluid comes back, we need to think about doing a second set of ear tubes. And here's that patient with their audiogram on the left showing the mild hearing loss. And then after the ear tube, they're a little bit older now, note. So now we're able to get information about the right and left ear, and now they're in the normal range. And that's a typical scenario that we see. Now we're going to talk about conductive hearing loss that's a little bit more severe than what we would see with fluid behind the eardrum. And this would occur, oral atresia is a fancy word for the ear canal not fully forming. If the ear bones were formed in a way that didn't allow them to move normally, and this would typically cause a severe hearing loss. And it occurs right in that area that I've shown with the box. And now this is a very zoomed in video during a surgery where we're looking down the ear canal, and that's the stapes and the incus moving, which is the second and third ear bone. And what we're doing, I'm touching the first ear bone and we're watching them move. And so that's how delicate, and again, this is very zoomed in. And to me, this is one of the amazing things about the ear bones is we have one of extremely complex system, right, about our hearing. And many times it comes down to mechanics of just getting the sound in. And so that movement that you saw in those very tiny ear bones, which are only a few millimeters when the eardrum moves, is what allows the sound energy to be conducted in and then sent to the nerve to process. And now, so in the instance of oral atresia where the ear canal didn't form, we've zoomed in here, we have the eardrum there, and so this area is often filled in with bone. When we have patients with oral atresia, and they can be with or without microtia, this is a typical timeline that I go through with patients. And in the top blue, we have the diagnostic information that we do. And Adriana talked about the newborn hearing screen and regular hearing tests. And that's one of the things we do in the first, very early in infancy. And then in the red down here, we have the different interventions that we offer. And you see the first box on the left that's red is the bone conduction. Here, this is the soft band. The headband hearing aid is an option for getting sound, getting access to sound. And we see we have early intervention listed there. And this graph also talks about when microtia reconstruction options come into play. But we're going to focus on the hearing interventions. And as and going back up to the blue, when we get to around age 5, that's typically when we recommend evaluating what's going on behind where we can't see. So if the ear canal is filled in with bone, we can get a CT scan, which allows us to see what's going on and what's the status of those ear bones. And we could consider an option for rebuilding that if based on the results of the CT scan. And then the other red boxes down here are the different types of bone conduction sound processors that Adriana was talking about. And again, you can attach that with a headband. You can attach that with an implanted post. You can attach it with a magnet. So there's a lot of different options that we have for access to sound. And so here's an example of a patient with a very narrow ear canal. So this is kind of it's a little bit of a spectrum, but the ear canal didn't fully form and the ear bones didn't fully form. And here's the hearing test results. So on the other side, the red is the right is in the normal range. And on the left, you see we have a pretty significant hearing loss. And this is what a CT scan. Now, when we look at this, I have them labeled here. There's a normal, I'm not able to point here, but there's a normal eardrum on the left side. And on the right, there's a bony covering over that. And so that CT tells us important information about what the options were. So one of the options we have is to actually do a procedure where we open the ear canal to make it a little bit wider and actually rebuild the ear bones. And so the video that I'm going to show next is, again, very zoomed in. And that is the third ear bone that we're touching with that little instrument there. So we're looking down the ear canal. And now that little metal circle there, that is a titanium implant that is about 3 millimeters. So it's super tiny. And now there's a little cartilage graft that's covering over that. And what we're doing now is we're restoring. Why don't we play that one more time, please? So now, what we're doing here is so that the ear bones, first and second ear bone weren't fully formed, and now we're reestablishing the connection between the eardrum to that third hearing bone in order to restore the mechanics of sound energy going in. And the way we do that many times is with a very small implant like that, and then a little piece of cartilage to rebuild the eardrum over top of that. And then here's just another example of a hearing test for somebody who has complete aural atresia. So the ear canal didn't form at all. And on the unaffected side, on the right side, we have normal hearing. And then we see the blue line shows significant hearing loss. In the CT scan here, you can see the very outer part of the ear. The left side is on the right side of the screen, so it's a little bit of a mirror image. And the ear canal is open on the right side, and on the left side, the ear canal is filled in with bone. And so this is aural atresia. And sometimes when we offer aural atresia repair, so we create an ear canal and open the bone and place skin in there and then rebuild the ear bones. Sometimes we don't get a perfect hearing result, but many times it moves it from severe to mild, for example, and then it also may enable the use of a conventional hearing aid that Adriana was talking about with the different color options and things like that. So here's an example of what it would look like before, and then this is an ideal result where the blue line on the left comes up above into the normal area. So in conclusion, I think, it's really important to understand the severity and type of hearing loss. Surgery is one of many options. And I think that's the key I feel like when I see patients that have this type of hearing loss, I want to make sure that they understand all the options. And you saw we have a wide range, right? Whether it's the post, the magnet, and so there's multiple hearing device options, and then there's also surgery. And I think, as Adriana was saying, access to sound is really important, and this can be done through a wide range of techniques. And now I would like to, we have a very special guest, and I'd like to introduce you to Austin Cole and his mother, Courtney. And Austin and Courtney, you guys want to say hi to make sure everything's working?
Hi, can you hear us?
Yes, awesome. Well, thank you so much for joining. So I've known Austin and his mom for quite a while. Austin, I was actually looking back in the notes, and it was 2016 when we first met. You were only 5 years old, and since that time, we've gone through a lot together, and it's really been my absolute privilege and honor to be your otolaryngologist. It's been amazing for me to watch you grow and develop into a young man. When they asked me to give this presentation, I didn't know that there was a patient spotlight expected. And then they asked, I thought of you guys. And then there was this amazing coincidence because Austin's family moved to Milwaukee just over a year ago, and we're, of course, in Seattle. And I hadn't seen them in a while. And there was a great opportunity to reconnect. And I thought they might be interested in participating from Milwaukee. And it turns out they just recently moved back to Seattle area. They're actually having a hard time getting an appointment to see me. We fixed that right away. And it was so great to see you guys last month. And thank you so much for joining us today and be willing to share your experience. So I have a couple questions, Austin. Should I just start, or do you want to say anything up front?
Of course.
So maybe do you want to tell everybody a little bit about yourself?
Sure. So I am Austin Cole. I am 11 years old, and I was born deaf in my left ear.
And how about your family, Austin?
Well, I have my amazing mom right here. I have my dad, and he is actually in the Coast Guard. I have my brother that has autism, and we have our dog, Weller.
And then do you want to tell us a little bit about how you learned about the diagnosis of Treacher-Collins syndrome and how that impacted you?
Well, when I figured out, or when all of us figured out we had, when I had Treacher-Collins syndrome, we were surprised, and we didn't know what would happen next. But the impact was the fact that I didn't really get to hear anything for most of my life. And it was hard to really enjoy things or really see in the way that other people do. But I did my best.
You sure did. And I think by the time I met you when you were just 5, you had already seen a lot of people and had moved around a lot. Is that right?
Yes. By the time that I had met you, I had gone through 2 or 3 moves.
And what was it like? So it was really hard to hear. Did you try hearing aids and things like that, or what do you remember trying early on?
Well, ever since I was 4 months old, we knew that I had Treacher-Collins syndrome, and we first did hearing aids, So I would have hearing aids every few years. We would get a new one, and they were very helpful and made me feel like I could really understand more.
And so I remember meeting you like really well in clinic and your family. What do you kind of remember about those early days when we were in clinic? I remember that it was really hard to do ear exams because the ear canal was so tiny and it was really sensitive. What do you remember?
I remember that I was. I remember that we walked in and you and I met, and then after a little bit we started doing a few hearing tests, and it was very difficult at the start when I still had pretty bad hearing.
To get the wax was hard. Yeah.
Right. Your ear canal was so narrow that a little bit of wax would like make the hearing a lot even worse because it would just completely plug things, right?
Yes, it would. The wax played quite a role in it. I remember before each time that we had a wax removal, I couldn't hear a thing, but afterwards, I felt like I could hear a lot more.
And then you went through some surgery, of course, and I'd love to hear kind of your and maybe Courtney jump in about kind of the decision-making process and what you guys kind of grappled with thinking about the option for surgery.
Well, when we first kind of found out about how there were surgeries and stuff to help with this, we weren't quite sure, but after kind of living through it and kind of getting to know Dr. Collins, we all got the courage and went in and got my surgery.
It was a long journey to decide if we were going to do surgery or not, and doing his wax removals at the beginning he would scream and it was painful and he wasn't about it. So we actually, Dr. Bly would put him to sleep and be able to clean out the wax. And then as we progressed, we talked about different options, and due to his ear shape, the hearing aid would actually come off, and the mold was hard to stay in as well. So we talked about some different options, and we did 2 major surgeries. And the second one, we were talking about this the other day, was 7.5 hours. And it was the longest 7.5 hours of my life. But Dr. Bly was so good and would come out and check with us and have the nurses call. And yeah, it was a long road, huh, bud? But definitely worth it.
Yeah, you guys definitely went through a lot, and even after all that, and so we did the surgery, and Austin got a lot of improvement in his hearing, but we're not completely out of the woods, right, Austin? Because your ear canal is not quite as, and there I am with the whole crew there, and this was right before I think you guys moved out to Milwaukee, right? And so we still need to do maintenance, right? And your hearing can sometimes still fluctuate a little bit, so it's not all perfect, right?
Yeah, it's been a crazy road.
Austin, do you want to talk a little bit about, because I remember, you had me almost like in tears in clinic when you were telling me kind of about what it was like in school and afterwards. And you remember you were so brave and like shared with your class and things like that. What do you want to tell them a little bit about that experience after you had the procedure?
So after the procedure, after just taking like a step outside, I felt like a new person. Like I could hear things the most clearly I ever have. I felt like the world just like said hello to me and welcomed me in.
Can make me cry.
And you gave this amazing presentation in second grade, and there's a picture of it right there. Do you want to tell them what that was about?
So I presented in second grade to my class after the surgery, and most kids in my class didn't actually know that I had Churchill Collins or even know what it was. So I shared about my experience and
Well, you read the book, remember?
right.
They read Wonder, and then they had a party, and he stood up with his class, and that's when he shared after the book was done and they watched the movie. He stood up and shared with everybody after that.
Do you want to maybe tell us, thank you, Austin, for all that. Do you want to maybe tell us a little bit about what you're interested in now in school? And I know you're taking a number of honor classes and working hard. And then this picture here just shows that, there's just been more, you've done a lot, and the medical world has put you through a lot. But do you want to share a little bit about what you're interested in now and what you're up to?
Of course. So I like Pokemon and hanging out with my family. I enjoy school, and my favorite subject is choir. And I don't know what's going to happen next, but
Nobody knows, Austin.
No.
But yeah, it's been a wild ride.
Well, it's been such a pleasure for me to, like I said, see you grow up. Courtney, anything else to add, or should we head to the questions time?
I'm going to say this without crying, or at least try to. It was such a special road going along with you. And when we said goodbye in that picture of all of us, when we thought we would never see you again, it was probably one of the hardest days, right? We were all boohooing. And then when we found out we were coming back here, you were definitely a highlight, because we sure think you walk on water, that's for sure. Because now this kiddo can hear and enjoy life, and it's so special. But we trust you with everything, and Austin definitely, built a great trust with you as far as cleaning out wax, and y'all worked out a system of raising hands and when you were good and when to stop. And now Austin's so good that you can go in and spend a good 15, 20 minutes and
right.
He does now. Yeah.
Well, I thank you. Like I said, it's been a privilege for me to, and you guys have done it. These are tough decisions, right? And we give you guys options, and you've been so thoughtful and made great, I think, decisions every step of the way, even when we needed to do, so thank you for that. All right, should we? And then, okay, so you guys got the slides. Thanks.
That people can go to after the program is over. All of these slides are available in our archive, and you can look at all the references that our two experts have brought to us today. But I have to say thank you to Courtney and Austin. And Austin, you are just about one of the most articulate 11-year-old young men I've ever met. So thank you for that. And I think what's exciting is seeing this is, a craniofacial condition is a journey, and seeing the partnership that the Cole family has with Dr. Bly and the team at Seattle Children's is what it's about. And it's not just a surgery. It's so much more. And that's what My Face wants to talk about and raise awareness about. And we just are deeply grateful for you sharing your story. And we're so excited that you read Wonder and you got to do that with your school. That's just great. So let's do some Q&A. If you have any questions, why don't you go ahead and put them in the live chat in Facebook or on your YouTube stream. We just want to make sure that to benefit everybody, we like to keep the questions general in nature, and then all of our special guests will answer those questions general in nature. So let's jump right on in. We have a really wonderful question that came in from a mom, and I'm going to ask Dr. Zanders to answer this question. One of the struggles we face is that my son does not want to wear his hearing aids. At this time, they are the only thing that sets him apart from other kids who weren't born with a craniofacial difference. Do you have any suggestions for how to overcome this?
Absolutely. That is something that we run into pretty frequently, especially as the kids get a little bit older. It can be difficult to have something that makes you stand out and be a little bit different. One thing that I always like to encourage families to do is trying to find someone who also has and shares a similar story. So like Seattle Children's here, we have like a social group that we do for our kids with hearing loss, and it just allows the kids to meet other people that also have a hearing device of some sort, and they can talk to each other and mix and mingle with each other, because sometimes our kids go to school and they're the only kid at the school that has a hearing loss or hearing difference. So kind of talking to your audiologist and whether that be your educational audiologist or your clinical audiologist, just to see what resources they have available in your town or in your state. Most states have some type of like family parent groups, social groups, and things like that, to kind of just give your kiddo some other people that they can kind of talk to and see and have some similarities with. So I think that's one. And then also trying to work, sometimes we have to use a little bit of a reward system, if you will, just to kind of encourage and help and show. Showing kids benefit, it can be really helpful. There's some benefit testing that audiologists can do to show how you do better with your hearing aids versus without your hearing aids. It can kind of be really helpful and good educational moment. And to just keep working on those things, some baby steps. Sometimes you just have to do it a little bit slower. But I would really start with trying to find some people that can share a similar story with your child.
So let me build on that. Courtney, did you have that challenge with Austin? Was he always compliant in wearing his hearing aids? And how did you deal with that if that was an issue for you?
Well, it was two parts. One is due to his ear shape, it would fall out. So that became fun. And at the beginning, we chose a hearing aid that was skin color, so it would fade in. Regretted that much later, and ended up getting one that had color to it, because if you drop it on the floor or somewhere, you can't find it. But we actually always made it positive. We never got after him over, you need to put this back in and stuff like that. But if he was not wanting to wear it at any certain point, we'd be like, oh man, you got invited to one of these parties or to go out to a restaurant or something, but you didn't hear because you didn't have on your hearing aid. And he's like, oh. And so immediately it was, oh, I should wear it so I don't miss out on anything. And so we just always made it a positive thing. And so we've just always been honest with him, and he started to love it. And then especially once the FM system started, that really helped too.
Yeah. Great. That's great. So a question, I guess this is a question I'll give to Courtney and to Dr. Bly. Families might be on the fence about surgery, and what factors do you remember that tipped your decision toward the surgery? Courtney, if you could start with that.
Go first? Okay.
Yeah.
Well, due to how Austin was growing and the results that he was getting from the hearing aid, he was missing out on a lot. And the FM system was lovely. We wore it at home. We would pass it along to anyone that we were with. It was great if he was out playing with friends in the neighborhood, because I could very quietly whisper in the microphone so he wouldn't get hit by a car, because he wouldn't be able to hear the car. And that part was great. But we talked about different surgery options, and we were honest with Austin, and we sat down and said, this is what we're thinking, and how do you feel about this? And it was just after the trust that we started building with Dr. Bly, we felt that was the right choice. And it took 2 surgeries to do it, but we're there.
Dr. Bly, I'd love to get your perspective as a medical professional, sort of how you walk a family through making those choices.
Yeah. Like I mentioned, I really try to give them the information, and really empower you guys to make the best decision, because you know your family best. We generally have these joint visits where you meet with me and then with Adriana or one of her colleagues at the same time, not often like right back to back. So you'll hear from me like a lot of the general information about the hearing devices that are available and the different implants that are available for those devices. And then it's followed right up with like a 90-minute visit with the audiology to like really learn about all those. And you get into the details of what the devices would look like and like which ones have Bluetooth and like all the cool features, right? And then in terms of the surgery, that's one of the options that's there. And I try to be very open with families, and we usually I'll zoom in on the CT and we'll look at it together, and I'll explain where we have. And depending on what we see there, some patients we think are higher chance for achieving a good hearing, achieving a great hearing result. Some patients are lower probability. So we kind of have that risk benefit, and I try to pass that on. And the other thing is time. Time is on our side. We this has been going on typically for a long time, and age 5 is the kind of a time point where a lot of those devices are FDA cleared and available, and that's also about the earliest we would offer a surgery like this. So we try to, over the years going up to there, because it is important to know each other, and we check on things. We make sure speech and language is developing, and so we're learning this. And then at age 5 we get the CT scan, and then we have that piece of data, and then we talk about the devices, and then often we'll just take some time and then come back another time and follow up and think about it. And so I think those are all important things when you're making a big decision like this.
Okay, great. That's wonderful advice. Dr. Zander, I'd like to ask you a question. The question is, my child's classroom is supposed to be using an FM system. I know you mentioned that earlier, to help accommodate her hearing loss. However, I've come to realize that the teacher often neglects to use the system in class, and it is sometimes burdensome or difficult to work with. Do you have any advice on how to make this easier so that the teacher will be more inclined to actually use the system?
Yeah, that's a good question too. I would say I think your first step absolutely should be to first check in with your educational audiologists. So the educational audiologists go to the schools and they kind of set up the FM systems, and then they are the ones that talk and essentially teach the teachers how to use the device. So sometimes a classroom has a lot going on. An average classroom has like 30 children in it. And then on top of that, you're trying to keep your classroom together, and you have this one kiddo that needs an FM system. So sometimes they just a little bit of a reminder and a little bit of help, maybe even retraining. I've kind of done some previous educational audiology work, and sometimes just going into the classroom, whether it be as a parent, but really having your educational audiologist really help facilitate that. So that we can just make sure that it's not like maybe they just don't know how to use it, or maybe they're not remembering the factors for it. You could also even ask your audiologist to give you some resources and some information that you can provide to teachers. I've done that before, where I've given teachers information that shows statistical data, like how important this FM system is for this child to be keeping up and to not fall behind his same age peers. So just advocating for yourself, advocating for your kiddo. And then as your kid gets older, teaching them to advocate for themselves. Sometimes teachers just need a little bit of a reminder, and having your child go up to their teacher and say, hey, can you remember to turn on my microphone because I can't hear you, is really good too.
Yeah, that's great advice. I'd love to build on that and ask Courtney, what have you had to do to advocate for Austin, especially in regard to the hearing loss, and if he, was using an FM system? Can you talk a little bit about that and your experience with that?
Of course. We started with early intervention immediately, and so he was in a pre-K program. And as soon as we could get an IEP done, we did, and that became my thing. Everybody calls me Mama Bear, coming in there and making sure that everything's written down. But building a good relationship with the school as well. And I mean, certain things like I went during an emergency drill at school, and I walked around and I checked the decibels to see, okay, when the alarms are going off and stuff like that, can he hear? And I even worked with the school, and we worked on hand signals and different signs to hold up, which even helps the kids that do have typical hearing. It's nice for the teachers to not have to yell or have to keep repeating, and they just held up certain signs, and that was it. And it was great. But definitely making sure the school is set and having that relationship together was huge. But Austin advocating for himself, and I always made sure that in the IEP he would advocate for himself, and that checking in with the teachers played a huge role.
Yeah. Well, I have no doubt that Austin does advocate for himself, because he really does. He's very articulate. I want to ask Austin, I unfortunately only have one more question, and I want to ask the star of our show, which is Austin. What advice would you give to other kids who have hearing loss?
I would say just be yourself. Try to.
It's okay, Bob.
Try to help each other.
Yeah.
Try to find people who are like you. And
yeah. All right. That's great advice. Thank you so much for that. Well, I have to say a huge thank you to Dr. Bly, Dr. Zanders, to Courtney, and to Austin for being with us today. This was a really terrific program, and we're just so glad that you were here. I'm sorry that we couldn't get to everybody's questions today, but if you have other questions that you would like to ask us, we ask you to send them to info@myface.org. And we're really excited to have this community of people who are interested in hearing issues. And so we wanted to share with you all some information about important legislation related to this issue. Allie Tumblin is a young girl from Colorado who needed a bone-anchored hearing aid, or a BAHA, that we talked about today, for hearing loss due to microtia and atresia. However, her insurance company refused to cover the cost of this device, forcing her family to purchase the device out of pocket so that Allie would not face any hearing or speech delays. With this, Allie and her mother, Melissa, took action to form a nonprofit called the Ear Community and created a bill called Allie's Act. Allie's Act would require insurance companies to provide coverage for medically necessary Osseo integrated hearing devices such as BAHAs and cochlear implants. This bill is currently under consideration in the U.S. House of Representatives and in the Senate. If this bill were passed by Congress, it could potentially save families thousands of dollars and would ensure that children and adults who need these devices can get them. The quality of life for children with hearing loss can be excellent, provided that they have access to corrective hearing technologies and skilled medical providers. This is especially true during the critical development years from birth to age 5. The Centers for Disease Control, the National Institutes of Health, and the American Academy of Pediatrics all stress the importance of early intervention to mitigate the impact of hearing loss on a child's ability to succeed in school and in life. MyFace agrees and has seen the positive outcomes children experience when they are able to obtain the hearing technology and services they need. Please consider sending a pre-written email to your representative asking them to support Allie's Act, please visit myface.org/Allie's Act to learn more. Because craniofacial differences can impact the body and spirit so significantly, MyFace provides important direct services such as access to patient and family support groups, all now virtual, topic-driven workshops, and online programs that serve to educate as well as entertain. These programs offer guidance, resources, and a supportive environment for all who participate. MyFace also hosts unique networking opportunities that seek to bring our community together, to empower the spirit and build strength, and let families across the nation know that they are not alone. For more information about our programs and services, please visit myface.org. We invite you to join us on Wednesday, October 26th at 12 p.m. Eastern Time for the next My Face, My Story podcast episode titled Exploring Face Equality with Phillida Swift, the CEO of Face Equality International. Please visit myface.org/mystory. You might also join us if you're in the New York City metropolitan area on Thursday, December 8th from 4:30 to 7:30 for our annual holiday party. Stay tuned for further information about this event. And coming early in 2023, we will have our next installment of our Transforming Lives webinar series titled Diagnosis and Management of Craniosynostosis, featuring Dr. Mark Urata, Division Chief and in the Division of Plastic and Maxillofacial Surgery at Children's Hospital Los Angeles, and with Dr. Alexis John, Pediatric Psychologist, also at Children's Hospital Los Angeles. For further information, visit myface.org to learn when that program will take place. At MyFace, we strive to provide the most helpful and informative resources. To help us do so, we ask that you take a few moments to complete our brief survey by visiting myface.org/hearing loss and let us know your thoughts about this program. We have also provided this information in the reminder email we sent, and you will be emailed this when you will receive an email after the program and have another opportunity to complete the survey. Again, thank you all for sharing your time with us today, and have a wonderful evening.